Ati, can you stop your video, please? Thank you. Good morning, good afternoon. I'm Benit Walter from the Secretariat of the Network for Improving Quality of Care for Maternal, Newborn and Child Health. Welcome today. This is the fourth webinar in a series on transforming care for small and sick newborns, which is organized jointly by UNICEF and the WHO in collaboration with the Network for Improving Quality of Care for MNCH. You will see that you are all muted on entry during the webinar, and this is so that our presenter can go through their presentation without any interruption. But we will have the second half of this webinar dedicated to question and answers. So we really want you to engage with the presenters. Please type your questions as they present in the chat box, which is on the bottom right corner of your screen. And please kindly send your question to all panelists and participants so we can all see them and we don't repeat the same questions. That would be very useful. We will read them out at the end of the session and the panelists will be able to answer them. I will now like to introduce you to your facilitator for this morning, Dr. Ornella Lincetto. She is a Senior Medical Officer for Newborn Health at the World Health Organization in Geneva, and she will lead you through this session. Ornella.
Yes, I should be able to share the slides. Can you?
Yes.
No, I'm not able yet. Meantime, good morning, good afternoon to everybody. Just a second that we. So welcome to this webinar, which is the third on the fourth actually on the report Survive and Thrive. That is a report that the WHO and UNICEF with many partners are, disseminating widely because of the importance of investing in the care of small and sick newborn, expansion as well as transforming how care is provided in order to accelerate the progress to achieve reduction on neonatal mortality. But also better thriving. And this is the topic of today's discussion, ensuring thriving. I'd like to introduce the presenters and the agenda of today. So the main presentation on the key findings of chapter 4 will be delivered by Dr. Gianna Patterson, who is a neonatologist, and she's the Senior Vice President of Global Child Health and Life Support at the American Academy of Pediatrics. Then we will have a presentation on an example of a neonatal unit in New Delhi, explaining, showing to us how in practice we can empower and engage parents in the care for their sick newborn. This will be delivered by Professor Arti Maria, head of the Department of Neonatology at the Dr. RML Hospital in New Delhi, India. And then, as usually, I will present a few slides on COVID-19, and today we will discuss a bit how COVID pandemic is impacting on early childhood development and how we can support the parents in this respect. And finally, we will close with, as usually, the question and answers. So thank you very much, and I would like to hand over now to Gianna Patterson.
Thank you so much, Ornella. It's really a privilege to be here to talk about how we can focus on those small, sick newborns to ensure that they thrive. We know that every newborn and young child's ability to thrive is the result of the environment they're in, the nurturing care and the positive interaction that they have with people in their world. We also know that all newborns, but especially those who had major complications during birth or during their neonatal period, need regular follow-up as well as nurturing care ongoing from the time they're born through their time at home in order to optimize their development. And we know that this is also good for societies, not just for the individual, but that investing in this early childhood development can benefit the individual as well as their community and their country. Next slide. So on that first key message of thrive, again, we know that newborns require nurturing care and positive interaction with their environment. But what does that really mean? It really means that an individual who thrives achieves their full developmental potential from the time they're conceived through early childhood. But this developmental potential, which we used to think of as mainly motor skills, we know now is much more holistic and includes cognition, social and emotional interaction, as well as language skills. And that those first 1,000 days from conception up until about 24 months of age are really a critical window in the context of preterm birth and neonatal illness and early child development. So thriving is this process of maturing through interactions between the child and their environment and family. Why is this period so significant? Well, we know that it represents a critical period in brain development, not only for the early childhood and newborn period, but for the lasting effect of a child's development throughout their lifetime. And we know again that this healthy brain thrives on nurturing care, and that lack of nurturing care can lead to lower cognitive, language, executive functioning, and psychosocial outcomes. And we know that nurturing care also can be protective when things in a child's environment are challenging. Early stimulation and responsive care can offset some of these risk factors. So investments in this care not only benefit the individuals, but communities and countries. Programs are needed that can deliver packages of interventions to provide this nurturing care in the first 1,000 days. We know that newborns who are at greatest risk of suffering from developmental delay or disabilities or poor neurodevelopmental functioning are concentrated among those who are born premature, low birth weight, or who are small for gestational age. We also know that babies who get infection or suffer from jaundice are also at increased risk. So how can we optimize development for these babies? All newborns, but especially these who are small and sick, need regular follow-up and nurturing care to survive and thrive. So how do we do this? We know at the center of this is a sensory environment that's supportive of the baby. And that includes the environment provided by the parents and family, as well as other care providers. So doing things to protect the baby's skin, optimizing nutrition, making sure they get sleep and are buffered from stress and pain, and have appropriate positioning and interaction are all part of creating that supportive sensory environment. Healthcare professionals can support this by recognizing behavioral cues of these nonverbal infants and by structuring the environment and incorporating individualized care provided by the parents. So you can see in the photographs here some examples of this nurturing care by positioning babies with swaddling on their sides where they have access to get their hands into their mouths, breastfeeding during painful procedures, and again, making eye contact with that baby and creating that bond between caregiver and baby from the very beginning. For parents and families, it's important to engage them early in the hospitalization of a small and sick newborn. We know this supports the baby by giving the mother's own or donated breast milk, by paying attention to hygiene, learning how to respond to baby's cues about hunger or discomfort, and again, coming back to that place of comfort and support for the baby that includes being fed, warm, clean, and supporting sleep and appropriate stimulation. All of these things together help to improve the emotional connection with the newborn and build confidence in the parent's own abilities. Kangaroo mother care is one particular intervention that is important, particularly for small and sick newborns. Colombia is a country that's had many years of experience in kangaroo mother care programs, and so they've been able to study it. There was a study that first was conducted in 1993 for babies that are under 1,000 grams at birth that showed the impact of KMC on survival and development. They were able to do a follow-on study some 20 years later that showed that the KMC had long-lasting social and behavioral protective effects. These were enhanced by a longer duration of skin-to-skin contact and by participation of fathers. We have other parent stories that are very important in telling us how to support these young babies. This is a picture of Elaine Bolaños Gonzalez, who founded an organization called Con Amor Vencerás. And this was in response to the experience she had in the hospital when her twins were born, and she was immediately separated from them, and the challenges that she faced as they had illness and struggled with some developmental issues. And she felt that she needed additional support and was able to find that by founding an organization for parents. So again, investing in early child development benefits the individual, but also communities and countries. This goes beyond what happens in the hospital, but into discharge from the hospital and beyond. So we know that parents and caregivers often feel lack of confidence about caring for their newborn after discharge, but supporting them to anticipate what kind of care the baby will need at home, supporting the parent's mental health and confidence is important as you develop discharge plans from the hospital that accommodate parent schedules, accommodate their learning styles, supporting them through the development of individualized education programs, and again, the ever importance of parent support forums. So at home, a parent can have great confidence in ensuring that their baby is fed, warm, clean, sleeping well, and comforted, and also knowing that they are a critical source of early stimulation for their baby. We know that this can have short-term benefits on their development in the cognitive, motor, and social emotional arenas. As a baby continues to grow, we know it's important to encourage that infant and young child to use sight, sound, touch, and smell to explore their environment, manipulate objects, and interact with the people in their environment. Delivering sensitive and responsive caregiving in the early days often centers around feeding. And we know that appropriate feeding practices are an important contributor to how children go on to develop and to their academic outcomes. We also know that parental stress levels must be minimized, and that by supporting positive maternal behavior, we also support positive maternal-infant interactions. In low and middle income countries, we know it's particularly important for children and their parents to be supported in this way and to have the appropriate nutrition. While, of course, all of this developmentally supportive care is important, we know we continue to need to be vigilant about monitoring for signs of developmental delay. So newborn screening programs and access to early intervention programs are a critical resource in societies. We know that assessment approaches are available for assessing individual children, as well as evaluating programs and monitoring populations as a whole. So being able to identify early these delays or disabilities and getting babies into an early intervention program can help to ensure the healthiest possible outcome. So while we're screening the newborn and the child for delays, we also need to make sure we're supporting parents by identifying those who are at risk for emotional distress or stressful experiences. We know that, of course, stress and distress can be amplified in humanitarian crises, and that staff need to be trained to screen for this parental distress so that families can get the appropriate care and support they need. Luckily, there are already great resources out there to help support this kind of care. WHO and UNICEF have global care guidelines for caring for the newborn at home, as well as the sick child in the community, continuing into the child's healthy growth and development. So those are the resources you see pictured here. So in conclusion, programs for early child development are critical to deliver in the first 1,000 days from conception through the 24 months of age. And it's not just to support the newborn, but to support the newborn and family through early detection of any delays, but also routine follow-up. And by supporting them in this way, we can provide developmentally appropriate care to improve outcomes for newborns through a family-centered, nurturing, and supportive sensory environment, so that with the right care, small and sick newborns and all newborns can survive and thrive. Now I'd like to hand it over to Professor Arti Maria, head of the Department of Neonatology at Dr. RML Hospital in Delhi. You may, thank you.
Arti, you can now present. Arti, I'm unmuting you now.
Can you see my screen?
Yes, perfect.
Okay. Good morning, good afternoon, and good evening. I will be presenting family participatory care as a gateway to nurturing care for sick and small newborn. I'll take you back to year 2007 in our unit, where the quality of care was as I have depicted. And the quality was rather disgusting, and I wanted to improve quality, but within the midst, I'm not able to shift my slides.
Yes, if you just go to your PowerPoint, you're able to move the slide like you
I'm
usually
able to move now.
Yeah.
Okay, so with that quality of care, I was stranded how to do it. And what I saw was a line of parent attendants always waiting over there to be informed about the child's condition. Lack of communication and human resource shortfall was the reason why quality of care was compromised. The thought occurred, can we start engaging the waiting parent attendants as nursing aides for their own babies? And then I started experimenting with this idea, allowing the parents to come in and started teaching them one-to-one, involving them in the nursing care as well as nursing aides in face of the human resource workforce shortage. And what did we see? We saw that the parents were happier simply because they could be with their children. Babies were getting a better quality of care. They were less often wet, alarms were ringing less, they were less often hyperoxic, and they seemed better cared. And nurses were happier because of the work sharing. So these were the fringe benefits we saw, but this amounted to a passive and instructive participation of the parents. So it was not like what we have evolved to today. This also made me realize the modern neonatal care gaps, wherein we pay much less attention to the sick baby's development, psychosocial needs of the family, parental and involvement in either care or decision making is severely limited, and the human workforce shortages compromise quality of care, and most importantly, there is a lack of continuum of care at home. Hence, we actually did a randomized control trial to generate evidence. And what we saw was that in the group where parents were, in addition to complement the care with the nurse and the doctor to the own babies, there, and this was compared with the group where there was a conventional care provided by the nurse and doctor. And to our pleasant surprise, there was no increase in infection. There was decreased hospital stay duration, much improved breastfeeding rates, and we demonstrated it was feasible and safe with a lot of parental participation. 61% were males, fathers were one third, and they were more than 50 years old, but less than half, and 25% were illiterate, demonstrating it was feasible for implementation. Thus, we had developed a standardized intervention tool by way of developing an audio-visual training module, which was structured into 4 sessions to train the parents and attendants. And the first one pertains to entry protocol. As you can see, this is an audio-visual training module. The second one pertains to the developmentally supportive care and involvement of the parent or mother in the activities of daily care. And this gives an opportunity to develop long-term bonding with the baby and being engaged in care of their own baby. This also involves, the second session also involves handling the baby, how to lift a small baby, breastfeeding, expression of breast milk, assisted feeding, and engaging in early childhood development and early stimulation and responsive caregiving. The third part of the session is about kangaroo mother care, being taught to the mother the technique, advantages to the babies who are eligible to receive it. The fourth session is about preparation for discharge, about the importance of immunization, picking up danger signs, reporting for early care seeking in case of baby's sickness, and reporting for, and continuing KMC and exclusive breastfeeding and essential newborn care at home. So what did we do and how did we do? Implementing at our own unit, we developed a structured protocol. How we institutionalized it at our place was that first at admission, the parent, among the parents who are accompanying the baby, sick baby, the primary care provider is identified, and there is sensitization about the family-centered care. Then daily trainings are scheduled for the parents who have come in with the new baby after the baby has been stabilized, and then this learning is enhanced through demonstrations of the skills as well as practice, and with the help of the audiovisual training module. And the next is there is a supervised learning in front of the nurse for these activities. And then there is a stage of peer-to-peer learning. The parents are mothers who have already been there. They're already in a state of empowerment and they've learned these skills. They're more than happy to teach it to the new mother. And this way they get more empowered and they are, very confident. And the new mothers also relate to them very well. This leads to this phase of independent doing, and then the baby is just ready for discharge. A counseling is done, and this establishes a linkage for continuum of care at home. So regarding the implementation, it was an iterative learning. And what we realized, what we initially did was, I'll take you through this journey of implementation. Mother became our point of focus. We thought it was all about training the mother, engaging the mother and capacitating her. But I realized that, it was much later that we realized mother need not be the point of focus because she was already sold out to the concept. It was much easier to tell her and expect that she'll do it religiously. That was easy. Initially, we were focusing more on the training sessions and ensuring mothers must attend. But I realized once they had learned the activity, it was more important to see them by the bedside involved in processes of care. So there was a need of supervision clearly, and that was the role of the provider. So that was the first lesson. We need to shift from trainings to involvement in bedside processes of care. Once we started involving them in processes of care, there was an observation that there was a tendency for the nurses to task shift. So it was important to define what mothers not only will do, more importantly, what they will not do regarding any of the medical care activities. Again, monitoring of was required, again, role of the provider. The next lesson I learned was that trainings were not happening regularly, frequent staff changes, new people coming, not aware of family-centered care. So I realized there was a need of periodic sensitization of the staff, one and all, right from the security guard to the head of the unit. And this again means role of provider. So what was not easy? It was not easy to implement. As simple as this intervention looks, it wasn't so easy to implement. And this was just our unit and facility. What will happen if I was to think of, spreading this to the community? So we had to develop a model which was implementable and scalable. So I realized much late in the course of implementation that selling the concept to the doctor, nurse, or the healthcare provider was the most challenging task. And therefore, focus needs not to be the mother, it needs to be the provider needs to be the focus for effective implementation of the program. This was the biggest learning. Now let's say why there were challenges with the healthcare providers. Is it because they have a challenge to accept parent attendant as a co-partner in care? Is there a feeling of diminished authority? Is there a watchdog effect and uneasiness because of being constantly watched? And there was a tendency to task shift? Or was it because they were expected to deliver a standard of care that an empowered parent now is aware of and expects from him? So identifying champions and getting healthcare provider on board is the single most important effective method to implement, and be sure it will be done so a mindset change will happen. Now we developed a way to monitor and develop measures of and attributes of implementation. What we developed was, one was measure of implementation with respect to workspace readiness, parent attendant preparedness, which was regarding practices, and the staff preparedness, which was attitudes. So essentially, infrastructure, practices, and attitudes need to be measured, defined, and measured to ensure that the implementation is happening in an objective manner. Then was to assess feasibility. And as I said, across the wide involvement of the demographic profile of the parent attendants, it's very clear that irrespective of literacy status, age, relationship, male or female gender, and it was feasible. Acceptability was demonstrated through a qualitative study by an external agency, and we showed that the primary gains through all the stakeholders were the empowerment of the mother parent or the father, and the skills were competencies were acquired and skills were acquired for care, essential caregiving of the baby, and there was establishment of continuum of care. And also there was improved patient-staff relationship, transparency of care, and trustworthy relationships, which is much the need of the day-to-day between the healthcare provider and the parent and the family. And more importantly, we were able to deliver much better quality of care. And this we were able to gauge and assess through the participation of the mother in the processes of care like nesting, positioning, cleaning, skin-to-skin care, etc., and feeding. And this is our data, and this is under publication. This is to show how the involvement of the mothers from almost nil to improve to about 70 to 80% regarding each of these activities. And what we did importantly was to make this important and not add to the work burden of the nurses to document it. We added these columns right in the routine monitoring chart of the nurses. All it needed was to tick for the nurse to say that these activities indeed were performed by the nurses. Now, this has been published recently about the acceptability, and it has been a very promising promising result that acceptability was there across the public health setting. Of course, monitoring is important, not only that the mothers are doing things under absolute care, but also the nurses perform their task as efficiently as they were supposed to. And we need to watch out for hospital-acquired infections and other adverse events. After discharge, we need to monitor whether there is a lasting impact through exclusive breastfeeding rates, KMC continuing rates, number of rehospitalizations, post-discharge mortality, growth, and development. So we were ready with this family participatory model, which had in place the improved provider skills, improved health systems because of infrastructural strengthening, and improved parenting practices given to the parents. And now we were ready for a translation in the public health setting, the country scale up. The government of India was very, very encouraging and supportive, and they said, let's pilot it in 5 model centers or 5 model district special newborn care units in 4 states of India before we actually embark on implementing it wider in the country. We were ready with all the resource materials, training materials, brochures, and the IEC material. And the scale-up the model 5 centers were implemented. What we saw was there was improved adherence, and this was done by NIPI. I must acknowledge all along their support for having this implemented, and seeing the country having seen the scale-up of this is fully attributable to NIPI. We saw improved adherence with addition of community component in the 5 centers where it was implemented. There was better compliance with health facility follow-up, with the prescriptions, with exclusive breastfeeding, and KMC rates markedly improved. After this, there was an encouraging need and demand felt for phenomenal scale-up of FPC in India, and it became a national health program by the government of India. Family FPC was then scaled up to 69 centers with the country budgets and all by the state government. And then the qualitative and quantitative assessment in form of an operational research was done in 38 facilities in India. And the tools were in form of health provider interviews, facility checklists, data verification, and client satisfaction and knowledge. And 38 such facilities were assessed. And facility observations showed improved infrastructural and strengthening, as well as the recordings were in place. There were adequate training places, and the logistics and the environment was made more conducive for implementation of family participatory care in this assessment. What also was seen was the quality of care was assessed, and it was found that there was improvement in various things like breastfeeding practices, KMC practices, nosocomial infection rates, as these parameters were already being recorded. The follow-up and community data from SNCU discharged babies also showed improvement, and there was aftercare at home was better. And it was also shown that the follow-up outcomes of 9,500 newborns after discharge showed improvement in mortality from 7% to 2%. The summaries of the findings, actually, to summarize, they were that most moms, they expressed a willingness and felt need to that FPC should start everywhere. There was enabling logistics were available at most places. Breastfeeding and KMC practices increased remarkably. And these are the numbers that how many mothers and parents received capacity building sessions, and how many babies received KMC, how many of them were exclusively breastfeeding and continuing KMC at home, and post-discharge mortality decreased from 7 to 2.7% after implementation. The learnings and challenges were that FPC is doable in public health framework. It seems to be a winning strategy for improving KMC and empowering families. It also it needs to be really not coming up yet as a vertical program. It needs to be integrated with the facility newborn care program already in place, and there is a need for scale-up support. So we have also done the assessment of neurodevelopment. Of course, since it was unethical not to give family-centered care once it has become standard of care in our unit. So we were able to do pre-post evaluation. And since this is a critical period of development perinatally and postnatally in the immediate part in which unfortunately the baby is most vulnerable when he's sick and in the NICU. So by getting the parents close to the baby and involved in care, this is likely to impact, that was the hypothesis, that it is likely to impact neurodevelopmental outcome with a long-term favorable dent. And we were able to show slightly lower rates of course, this was not an ideally planned design study, but this was just hypothesis supporting and, generating that against the backdrop of family-centered care, there was adverse neurodevelopmental outcomes were lesser in the group. Just to say that now, if we look at the entire model and how there is a linkage between family-centered care and early childhood development, if we start with the center around the smaller sick newborn, and if we, against the background or canvas of family-centered care, we can see that at facility, there is nurturing care through learned competencies, involvement of the parents in processes of care. At community, there is empowerment, there is linkage for continuum of care, and this is likely to provide a nurturing environment and improved early childhood development. Hence, family-centered care is a humane way to care. It's a gateway to nurturing small and sick newborns. It creates opportunity for lifelong bonding. It's a family's right to a respectful care. There is a need to protect, support, and promote. It seems to be a winning strategy for KMC scale up. Operational feasibility and acceptability in Indian healthcare setting seems promising. And if you remember, initially I said it was a passive, instructive participation of parents. And now we have evolved to a level of transformative participation. And that now, if you understand the transformative participation and partnership between the healthcare provider and the family through family-centered care, is likely to bridge the gap between hospital-based newborn care and home-based newborn care to improve neonatal outcomes. And thus, I wouldn't be speaking more if I said family-centered newborn care holds the key for developing social accountability of health, because health belongs to people, health belongs to community. And so it is the key for developing social accountability of health to help to achieve sustainable developmental goals. I would like to acknowledge NIPI, USAID Assist for helping us with quality improvement programs, INCLIN for providing us technical insight and some development of tools, national and state governments, all the babies and their families for participation and consent for pictures, and our unit staff, doctors, and all administration and authorities at our own hospital. And I want to thank the organizers for giving me this wonderful opportunity to share my work with you. Thank you so much.
Thank you very much, Aarti, for this very detailed presentation. I'm now giving the floor to Nella Lincetto again to talk about the COVID context.
Okay, so thank you very much for my previous presenters, and we now would like to see how this discussion can be reflected. How can we on the considering the current pandemic, and we know that we are struggling at the moment on a number of issues related to the pandemic and the maintaining the essential services for mothers and newborns. We are also struggling with avoiding underutilization of services, as well as ensuring that if a woman of a newborn gets COVID, they receive appropriate care. And in addition, we are worried about what could be the long-term effects of a number of the pandemic on the development of the current generation of newborns and children. Because there is an economic impact of COVID, as we can see, in terms of increased risk of poverty and food insecurity, but also loss of caregivers and less access to neonatal services, as well as psychological impacts that can be due to the stress that and even depression that the caregivers may experience, and therefore having less capacity or willingness to provide nurturing care to their babies. And this is might have an effect on the entire life course of the child. So what can we do? So first of all, in terms of, we needed to ensure that we continue to provide responsive caregiving, health and nutrition, and all those important components of nurturing care when we provide the services for mother and the newborns in line with what has been discussed during the day. Also in the context of COVID. So this means provide family-centered care and during at the time of birth and during the hospitalization of healthy children as well. I mean, in the postnatal period as well as hospitalization of small and sick newborns. It means provide the pregnant women and new mothers with counseling on breastfeeding, and also on the issue of non-separation, but with proper IPC procedures. It means using health and nutrition platform to deliver messages on coping, on parenting, on providing early stimulation and a supportive environment, a nurturing environment for children, promoting family and washing in the hygiene because that protects against COVID. And of course, in the situation where there is also the problem of food insecurity, providing supplies as needed. But it means also to think about the ways of supporting nurturing care, security, and safety during the pandemic response in terms of including early childhood development in the response to protect the future generation of children. And this can be done also by reaching the parents with the needed information, but also sometimes with support, mental health support, and encouragement and ideas and tools on how to provide a disciplinary environment for their children despite the restriction or the stress that is created by the COVID-19 pandemic. It means also to identify and target those children or those families that might have that might be at higher risk, and support the parents to provide the care that the children need. And but also it means to identify the parents, as we said before, that because of the COVID or during the COVID are at higher risk of not being able to cope because of social or psychological constraints. And so to be sure that despite the restriction, we can provide them with the support they need either through visit or through tele consultations or through more intensive kind of support. And then, of course, ensuring that we have in place to support women and children at risk or who are experiencing domestic violence and abuse, because unfortunately the COVID pandemic has exposed also this additional risk in some situations. And there are a number of tools and resources that WHO and UNICEF have put together in order to support healthy parenting and mental health in the context of COVID. Some are tools more for care providers in terms like operation guidance to maintaining health services, or the tools that have been a set of tools provided by others are tools really for not only the care providers but also parents that you can see in the last link that I provided. The others are infographics with ideas that you can find, or for campaigns even that you can use for advocating for nurturing care in the context of the COVID. So I conclude here, and we can move now to the question and answer, and I leave here the slides for the next, that is very rich for you to know how to connect also with some of the initiatives that are in the area. Particularly, I would like to highlight to join the community of practice for the chaos and sick newborn event. Thank you.
Thank you very much, Ornella. So we have got a few questions while the presenter were presenting. The first one is from Jana, from Sophie Janet, asking if we should promote KMC in term babies in humanitarian and emergency settings to help ensuring all newborn will thrive.
Thank you, Benny. Yes, we know that KMC is something that can be good for all babies, and it's been somewhat of a topic of debate of when to not apply KMC. But we know that nurturing care and touch and promotion and easy access to breastfeeding is something that all babies can benefit from, and particularly in humanitarian settings, continuing to foster that bond between the mother and the newborn and giving baby easy access to breast milk is critically important, even if they're not small or sick.
Thank you. We have a couple of questions for following Artie's presentation. The first one from Neha Sood on whether there is any impact study that is being conducted after discharge, for example, for care at home of the sick and small newborn. Artie, you're on silent. We can't hear you.
Yeah. Can you hear me now?
Yes, thank you.
Okay, so the question regarding the impact study after discharge, as I already demonstrated, NIPI had undertaken a facility and a follow-up study on 38 facilities after discharge, where the implementation had happened, and they had already shown the data. It's an operational research. It's not the ideal kind of a setting like a effectiveness study which has been done. So it is on the field what it was, and they showed that there was improved follow-up rates and continuing rates of KMC, and there are certain outcomes which have not been assessed. We are planning to do a study on a bigger scale for not only implementation outcomes impact, but also on how to strengthen this community take-up of family participatory care through strengthening of the frontline workers as a bridging manpower between the facility and the parents.
Thank you. There's another question for you, Artie, also from Neha, asking if you think there is a need to do a study on the workload for nurses because they are not being processed as per norms.
Yeah. So if at all, initially there was a mindset block. They were not open to implementing. They thought it was more of a job to actually additional work to train the parents. And they said, what is the benefit we get out of it? This is an additional workload for us. But as the time has gone by, as the mindset and attitudes have changed, they saw the goodness of this. They saw that, in fact, now the parents coming in, they have their work for these simple activities, which are very well performed by the mothers who are very happy to take care and engage in their own babies' activities. Their workload has decreased with respect to these activities, whereas they are left with more time for doing the more skilled tasks, and thus they can spend more time preparing fluids very aseptically. Otherwise it's impossible that they did all those works, and plus they have seen the advantage of trustful relationships coming through. The mothers are now no longer they are pointing fingers or they are finding mistakes. They're aiding the nurses as well, as very happily so. We did try to do the motion studies initially, how much time it's saving or not, but eventually we realized that the best proof of the pudding was that the nurses Today, if I give them a choice, do you want to continue or should we leave it? They all stand by and say unanimously that they want to continue this. And this is mutual between the parents, families, and the nurses. So it has landed us with a great, respectful, equation between the parents and the providers.
Thank you. There's a follow-up comment from Yara on this saying things actually nurses are supposed to educate and train parents as well. And she thinks it would be important to modify their job responsibility as well to support that.
Yeah, certainly. And that's why we have this tool, which we have made audiovisual tool. It comes very handy and it has given a structured kind of, what to train, to what extent and how to be, what is the content. All that has become very easy with an audiovisual training tool. And the mothers, in fact, it's become a standard of care. All mothers are now aware of hand washing. In fact, our hand washing rates for the healthcare workers, the doctors, nurses has actually improved because no mother will allow a parent, any other person to be touching their baby without hand washing. So they are like silent observers, like watchdogs.
Thank you very much for this answer. I have a question for Onela on the COVID context from Rati Wolandaro. I apologize if I probably mispronounced your name. Asking if there is any adjustment for implementing KMC during COVID-19. Onela, you're on mute. We can't hear you. Okay. I just, Onela, you are on mute. Can you start again, please?
I'm mute now.
Yes, you are.
Yeah, okay. Because I was seeing the slides, I couldn't see the. So yes, of course we have to. But first of all, it depends if the mother is COVID, the mother or the baby is COVID positive or not. But in general, we are strengthening everywhere the IPC precautions because sometimes we don't know if the status of the person. So that is certainly a must. Then the facilities need to have a bit more distance between the beds, babies as well as babies and mothers, so at least 1 meter. And so that the famous social distances and washing hands, etc. And then if the mother is COVID positive, she can still provide skin-to-skin care, Kangaroo mother care, and but she needs to wear a mask until she's not more infectious.
Thank you very much. I have no more questions at this point for the presenters. So I'm just asking people if you have a few more questions, type them now. Otherwise, we will wrap up. I wanted to say I got several questions to me asking about the presentation. So yes, we are sharing this presentation. You will have a link tomorrow with the two presentations from Professor Maria and from Dr. Patterson on your email for all of you who have registered, as well as a recording of this presentation. And you will have also the question and answer there. So it will be on the Quality of Care Network, and you can see all the other recording as well. If you have no more questions, I will hand over back to Onela for the closing comments.
Yeah, so, you see the screen?
We do, but this is...
But it's not the correct one, is it? Yeah.
No. This one, yes.
Yeah, so I want to thank you very much, everybody, for your participation. It's not an easy topic when we are talking. I mean, the thriving component, I think, is much newer compared with, in the conversation on newborn health. We are struggling to ensure that we are providing the services for sufficient and services, both the coverage as well as quality of services for the babies who are admitted in the hospital because they are premature or because they are sick. And I know in many countries it's quite difficult to put in place those elements that are really important for the nurturing care, both during the hospitalization and even more when the baby goes home. So it's really a new area of work that requires a lot of thinking, requires a lot of transformation, and especially for the countries that are expanding the services, it's very important to take all these elements into consideration as they develop their services, because there are also issues, some issues of infrastructure or of policy that allows parents to be present in the facility, as well as organization of care both during and after the discharge. So but thank you very much for your participation. The next webinar will be on the 1st July, and in this webinar you can see the links. In this webinar, we will discuss the use of data for accelerating progress and action for the care of small and sick newborns. Thank you very much, and have a very good day.
Thank you.